This episode is brought to you by our sponsor, Artery Inc. You've probably heard me mention their vast collection of artistic, anatomy-inspired apparel, but I'd also like to highlight some of their other items, such as the Show Me Your Guts coloring book for adults, which is really cool. So I would encourage you to go check it out to see what exactly is in a coloring book for adults that has to do with anatomy. It's pretty amazing. Use the link in our show notes or go over to www.arteryinc.com, that's INK, and use the new code. This is a new code, as I said, listen to PHP at checkout to receive 10% off all orders over $35. You'll save some money and you'll show your appreciation for the show. Note that the discount, however, does not apply to subscription boxes. Let's get to the show. This podcast is for informational purposes only. It is not intended to provide medical advice. It exists only to entertain. In a modern U.S. emergency room, a doctor introduces himself to a new patient. Hello there, I'm Dr. Max. What brings you to the ER today?
I'm having abdominal pain. Started last night. I was hoping it would get better, but it's getting worse, so I came in.
Okay. Can you show me where the pain is?
Yeah, but wait. What's that on your badge?
My badge? What do you mean?
Yeah, it says DO. What does that mean? What's the DO?
Oh, that's just my title. I'm a Doctor of Osteopathy.
Huh? I'd never heard of that before. Oh, why doesn't it say MD?
Well, it's kind of a long story, but there are basically two types of medical school in the U.S. It's a historical difference, but I can assure you, I do all the regular doctor things.
Does that mean you're a bone doctor?
No, not exactly. I can see why you'd think that based on the wording, but I'm not an orthopedist. I'm an ER doc.
But why wouldn't you just get your MD, though?
A DO degree is the same as an MD in basically all respects. Can we just talk about your abdominal pain?
Wait, you are a doctor, though, right? I thought MDs were doctors.
Yes, very much. Board-certified emergency medicine specialist with DO at the back of my name. That's all.
Then what's the difference?
It's more of a historical difference. I mean, I went to medical school where we learned a bit more of the musculoskeletal and kind of some spine manipulation type stuff in addition to the normal medicine-y stuff, and, so...
So like a chiropractor?
No, not like a chiropractor.
Oh, don't they do that stuff?
Yeah, kind of, but not exactly. I mean, look, there's a nuanced difference between the two that would take a little long to explain here in the ER, to be honest. Can we just get back to the abdominal pain?
Okay, but when do I get to see the doctor?
I am the doctor.
I mean the MD.
Look, I can see where the confusion arises. I promise I'm a real doctor. DOs do all kinds of medicine. We do this in the emergency room. We deliver babies. We do cardiology. We do neurosurgery.
Okay, so you're telling me there's no difference between MDs and DOs?
Overall, correct. Except the other thing.
What's that?
We believe the liver pumps the blood.
What?
I'm just kidding.
Throughout history, it's just Max and Mary, Mike and me. You gotta listen, you don't have to read. For historians, for historians, for historians.
Welcome, everyone. This is Poor Historians, a podcast delving into the archives of medical history. As three emergency physicians, we will explore the unusual ailments, treatments, physicians, and all related material having to do with the healing arts. I'm Max, and I'm joined here by my good friends and colleagues, Aaron and Mike. Gentlemen, are you ready to fling a banner to the breeze?
Sure.
I'm not quite sure what that means.
I don't know what that means.
Is that a Clash of Clans reference?
Sounds fine. Sounds like fun. There's breeze. That sounds like fun. Let's do it.
Like Drew Brees?
No. But I am not surprised. That this is a very. I'm pitching some inside baseball here. You'll find out.
That means we're going to turn on those and we're going to take them out of the park.
Yeah, not quite. Anyway, So we'll get to whatever that means in a little bit. But in the meantime, I've got a shout out for us. So this show's shout out goes to Dr. Nick, a specialist in blood bank and transfusion medicine. And that's for taking the time to write to me and say, hey, I heard your episode on the history of emergency medicine. We mentioned his specialty as like one of the newest ones that since the foundation of emergency medicine, many specialties came along. Transfusion and blood bank medicine is one of them, and he wrote and said, hey, that's what I do. Kind of gave me a couple of really cool behind the scenes tidbits on his job. And he also, my favorite was the closing, where he basically said that he is the doc behind the scenes that makes sure we ER docs don't hurt anybody with blood transfusions. So we do appreciate all the efforts. Told him as much, and told him I'd give him a shout out. So thanks, Dr. Nick. Appreciate all the preventing us from transfusion reactions. And this is not Dr. Nick from Simpsons.
I know.
Guy.
When you said that, I was like, Dr. Nick. Hey, everybody, I'm Dr. Nick.
Dr. Nick Rivera should definitely not be in charge of blood banks and transfusions.
He's one of the greatest television doctors ever.
I would not trust him with anything, but I kind of want to meet him.
There.
That's
a good debate.
The doctor from Arrested Development's good.
It's one of those shows that I know I've seen a few episodes of, and it was very enjoyable, but I didn't get to dive into it.
Oh,
yeah.
He comes out whenever he's got news to deliver, and he gives bad news in a happy way, but it says it so vaguely that he gets surprised that the family is like happy. Like one of them where this. Yeah, I don't want to. It's a spoiler alert. Buster gets his left arm bitten off by a seal. A loose seal, and his mom's named Lucille. But he goes, I just want to let you know that Buster's going to be all right. And they're like, oh, thank God. They're like, I'm surprised. A seal bit off his left arm. That's why he's going to be all right.
I would watch that episode.
You should. It was funny.
And
then the doctor from 30 Rock, he's good too.
Yeah, fair enough. 'Tis time for the new segment, Mike's mailbag. Mike, are you ready this week?
I think so. Yeah, I'm kind of like, I'm understanding the assignment.
We're getting there. So we have a submission to Mike's mailbag this week. And this is, again, the segment where we solicit a question from the audience, or you send us a reference and something you want to see if Mike knows off the top of his head without researching it. So he doesn't know what I'm about to ask him. And this week's quick interjection for our listeners, to be honest with the fact that I accidentally had the wrong name attributed to the submission this week. And so in an effort to seamlessly correct this, I went back and overdubbed the audio. I don't think you'll notice. Or this episode's question comes from a listener named Jake. His name was definitely Jake, who wrote and wanted to know, when was the first vasectomy done? Mike leans back. He's thinking.
No, I know the answer.
He knows the answer. Okay.
So it was actually documented fairly clearly in Egyptian hieroglyphs. They found a papyrus scroll that dated around the time of Cleopatra. So this couldn't have existed on the Great Pyramid because Cleopatra lived, I think, thousands of years after the pyramids were
that is correct.
Constructed. So, but yeah, there was a physician of the time by the name of Parasclepicus.
Is Parasclepicopolis, actually.
Yes. Well, no, but he did. He moved from Greece to Egypt.
Yeah, we all know that.
So yeah, this physician used a sharpened reed and back then they flayed open the entire scrotal sac and had to briefly remove both testicles. They said it didn't make a vas deferens where they made the incision back then. And then, so yes, it was that year, whatever that year was.
Anatomy jokes, everybody. Anatomy jokes.
Wow. Points for the anatomy pun. I'm going to give you points, but you're very wrong about almost everything else.
Can you not use a sharpened reed to fillet open someone's scrotal sac? That's
part of where it went off the rails. Okay. Yes. So the actual answer, and I looked this one up. Who would have thought that the vasectomy itself, the procedure where we disconnect the pathway from sperm from the testicles out through the prostate and out the urethra, the procedure to disconnect that actually has a very dark backstory, it turns out. So I don't know if our listener was aware of this, but the first vasectomy performed on people was actually kind of a non-medical reason. That was in 1899. A physician by the name of Dr. Harry Sharp, which would be a whimsically funny surgeon's name if it wasn't for the fact that he was a eugenicist and did this on a 19-year-old inmate to force sterilization.
Oh,
But they didn't castrate. So this was a way like to
correct. So the difference between castration and vasectomy. Castration is removal of testicles. That was the really dark start, but so in 1900, however, Dr. Harrison actually published the first cases of doing this for medical reasons. And you know what they used to treat it? It wasn't really for infertility in that respect. It was to treat BPH, benign prostatic hypertrophy, and enlarged prostate, which it does not do. But the thinking at the time was they noticed that if castration occurred, then the prostate would shrink. So no more testicles means no more hormones to keep the prostate enlarged. And so it will work if you remove the testicles. But they thought maybe we just sever the connection and it should work. And it didn't. But hey, they tried something. So there you go. First vasectomy for people.
It's funny because I said the Cleopatra thing and then I didn't know when she lived. So that's why I didn't say the year.
You're actually pretty close on that.
She was in the way back.
Mm-hmm.
So that means Jake has stumped Mike, which means he gets his own eponym, a feature in medicine named after himself. So what you may not be aware of, gentlemen, is that there is something called Jake's thumb, which is also known as fisherman's thumb. And this is where frequent catching of fish and holding them up for pictures, holding the fish by the mouth results in inflammation of the base of the thumb. And it basically causes it to gradually kind of bend downward, almost deforms it a little bit. So people with Jake's thumb can be stigmatized due to their inability to give a thumbs up. You just don't really know if they approve of something. And though they do know the cause, like the people who have this, they know the cause of the condition. They love to fish. They just don't stop. And that's how fishermen do. There you go.
Jake's
thumb.
Nice.
There's actually a perception of it's a psychological disorder as well, because like things seem larger than they are, because when they take pictures of these fish, they're often held in perspective close to the camera to make them look bigger. So they think that everything looks bigger, so they have some issues there.
Are you saying that by their nature, fishermen are deceitful?
Yes.
That's what you're saying?
But it doesn't harm anybody, correct? It's just for them.
Well, right.
Until they put it on their Tinder profile. Then it's...
What?
True story.
Wait, is it catfishing or fishing?
No, actual fishing. Anywho, so...
It's like internet personality. The guy with the fish on his Tinder profile is an internet personality. It is
a thing. It's definitely a thing. Well, gentlemen, I didn't even know this until I was researching this episode, but it's just so happens that it's National Osteopathic Medicine Week.
That's not a thing. When do we get Allopathic Medicine Week?
It's on the website. I think it was on the AOA's website, American Osteopathic Association. So it's a thing. And you would think that I would know that because on this show, I am the only DO. I am a doctor of osteopathy.
That is true.
And I've been teasing for a while that I wanted to cover a history of my own degree. And I decided to take the occasion to regale you with a history of the profession, this part of the profession of medicine. And so I asked you guys before we started recording, do you really even know anything about this? And both of you were like, no, actually, we don't.
I mean, it's true. There is no distinction at all. I mean, I work with a ton of DOs, and they're the same as MDs. So...
But even so, back in medical school, like I didn't know that this existed. Like when I applied to medical school, I applied to 2 schools. Actually, my son recently was like, "Were you insane?" Maybe it was a different time. He's like, "Did you not want to get into medical school?"
It was a different time for sure.
It's like you got to apply to like 30.
Yeah, I think I applied to like 6 or something. Yeah.
Yeah, but I had no idea that this was even an option.
It's funny because we're going to go through this, but I had suspected. I never really sat and asked the MD, the other side of this. I never really asked like your inside knowledge of the DO world, and I realized that there might not be a lot, and so this might be kind of interesting for both of you. And because this was something that many of us may have like really fixated on during our training, and we'll kind of go in why. There's a lot behind it, but
just to interrupt, I think it may have to do with what state you live in. Because there's some states are very like DO. I feel like Ohio has a lot of programs. Illinois has a lot of programs. There's none in Wisconsin, so we wouldn't we wouldn't really
It
be
is
aware.
definitely, there are some regional specifics. We will talk about a very special case too. But yeah, so I, as a real living, breathing doctor of osteopathy, am going to take you through this. And this has been a topic of interest to me since I was in school. I've definitely teased it before, that we were going to cover it. I figured, you know what, it's time. And so as I said, I didn't really realize it was National Osteopathic Medicine Week, but I appreciate that coincidence. And that shows you how hardcore of an osteopath I really am.
Mhm.
So it's fairly likely that a lot of our listeners have probably been treated by a DO, a doctor of osteopathy, at one point in your life or another. And my experience has been that most patients haven't even realized this. In fact, they don't realize that I am a DO until they squint at my badge and they see my name followed by DO. And this leads to a conversation which you pretty much heard in the beginning of our show that I haven't maybe had exactly the same, but it almost follows word for word. And I've had have that conversation many times, and it's vexing because
that would be
when you ask what's a DO, all of a sudden I've got a patient on the other side who's like, wait a second, I thought I was seeing a doctor. And then I've got to kind of summarize this history of like the whole wing of my part of this profession in like a soundbite. And at the same time provide reassurance that, nope, I'm a real doctor. I do all the real doctor things. And you guys probably don't deal with this, but this is something that kind of comes up a lot because my degree technically reads differently, right? So nowadays, you mentioned it, I think, Aaron, that you guys haven't really noticed this because DOs are so interchangeable with MDs that basically in all but title. So you find them in doing family practice, internal medicine, cardiology, neurosurgery, all the specialties. You can be a DO, it doesn't matter. But there was a historic precedent behind the distinction in the title where that wouldn't have been the case many years ago. And so DOs historically have wanted to maintain the DO-ness or like kind of this distinction, even as it's been kind of increasingly difficult to tell them apart, from MD colleagues. So the DO difference, it all begins with a response to a medical tragedy in 1864. And a man named Andrew Taylor Still, we call him AT Still in the business, had lost his entire family, all his close family, to meningitis. And I mean, like his wife, 3 daughters, and an adopted child all died due to bacterial meningitis. And it's an infection around the brain. It's serious today with
like at the same time
antibiotics. But within the same year. I don't know if it was like the same short period of time, but it was the same year. So I'm sure it probably went person to person in the household or something to that effect. But, then was obviously way before antibiotics, and we have antibiotics now, and this is still a very dangerous infection, which is fortunately more rare with vaccination. So, when something devastating like that happens, people respond in all sorts of unique and interesting ways. Epic tragedies will do that, but AT Still decided to totally rethink the principles of medicine as a result, which, at least sounds like a productive way to go about it, but it's also kind of an interesting way to go about it. So this was at a time when bloodletting and leeches and like what we think of as historic medicine, that was what was done. And so this was the time when doctors were supposed to do something and not just stand there, even if that something really didn't help. And that's what they did. They did all the things that they could.
That's our show. That's our show. All the stuff that didn't work, essentially.
That's the subtext of medical history to be sure. But yeah, so they did everything. They did the bloodletting, they did the leeches, and the idea was that if you weren't doing something heroic, it probably wouldn't help. But you could put all the leeches and drain all the blood from somebody who has bacterial meningitis, and it's not going to help. It's not going to cure it. And AT Still was very frustrated by this. I'm probably putting that as a massive understatement.
I'm frustrated. My entire family died of meningitis. Oh, it's a humdinger of a life, but I'm going to get there and I'm going to make things better.
He was known for his stoicism. So he thinks, AT Still, he's like, well, there must be a better way. And that plants the seeds of osteopathy.
Definitely true.
Yep. Well, let's go a little bit into AT Still's medical background. And there's not really a lot of formal one. So according to my research, what was the difference? Charlatan and what was it? What's that?
Quack.
Right.
But he wasn't a quack, right? Because he didn't have a device. He didn't have a degree for which he professed.
Technically, he did not have a degree. Yep, we'll get there. So he did not have a formal medical degree, right? So what ended up happening, basically, this is in the 19th century. And in the 19th century in the U.S., and we're really speaking specifically about kind of the way medicine was done in the U.S., there were a lot of docs who really never went through formal training. It sort of was like you might apprentice under somebody, and it wasn't uncommon that if you kind of got in with the right people and they knew the right people, you might end up a doctor without like a really formal education at that time. And so AT still kind of took that route. He apprenticed under his father, who apparently was a physician. And after that period of time, I don't know how long that was, AT still goes into service in the Civil War. So he actually joins the military. He was with Company F out of Missouri. He was on the side of the Union, and he worked as a hospital steward. Soon thereafter started, as he kind of went up the ranks there, he described himself as a, quote, de facto surgeon. This is in his autobiography.
Essentially, am a surgeon. I could do anything they can do, but,
Yep.
look over there.
Well, in other words, yeah, he was pretty much...
yeah. Although at that time, yeah.
I guess all of us, we would have been de facto surgeons, too.
They're like, here, take this saw. There's the pile of soldiers.
If you were willing to do it and you were around people who did it and you learned how to do it, at this time, especially in the U.S., that was not a totally, that was not a completely unique path into medicine, as it were. And so basically, in other words, he was just as good as any other surgeon in Civil War standards based on the training and what they knew at the time, but he just didn't have the formal training. And that should inspire confidence in the treatment of his patients
and the entire profession.
Yeah, for sure.
Now, like I said, he was a hospital
We were the people
steward.
that picked up the saws.
I'm willing to. I'll amp that leg. Whatever.
Do you want to play a little game?
So, it actually was not uncommon for these hospital stewards in the Army to kind of be promoted to roles like even surgeon. And so, that's just kind of how it was. The circumstances in the Army encampments were awful. And so stewards would also function as pharmacists if they were good enough for, at the job, and like just general medical staff. So,
there's
there you
like
go.
4 bottles of, so,
tincture of opium, dry opium.
Don't forget your arsenic and mercury.
Arsenic and mercury. Yep. There you go. That's the 4. That's
it's all you need. But it should be noted that a little bit after his service in the Civil War, AT still did look for some further medical education. He completed what was described as a, quote, short course in medicine at the then new College of Physicians and Surgeons in Kansas City, Missouri. That was in 1870. I'd like to imagine it's like a correspondence course or something to that effect, but I'm not really sure how long it was. I do believe, however, that's the last formal training he received prior to founding osteopathy.
How old is he then at this time?
Oh, I don't remember.
Young man, older man?
He's probably 30s, 40s. I'd have to look up his birth date and do a bunch of advanced calculus, which I just cannot do right now.
X, all for X.
70s, so they all had kids when they were 12. So
he was so we can look it up later. But
like
he's probably
28.
He's probably in his 20s, 20s and 30s. I'm guessing.
In this figure, because we don't really. I guess we have in allopathic medicine, we have our like old guard, right? The Asclepius, the Hippocrates, and all of that. Is this like the new guard of osteopathy? So this is something that everybody knows. I mean, the father of osteopathy, but this is like
this
a story
is the founder. This is the guy who started it.
Osteopathic school. Do you research this yourself and figure this out, or is there a class where they're like, here,
Good
this
question.
is
the history of the osteopathic profession? I can only personally speak from my experience in medical school, but I think it's fairly universal, is that DOs are very proud of the history, and the schools, certainly are strong to teach a lot of the history. So we got like a whole history of osteopathy in the class where we learned the tenets of osteopathy. I suspect it's probably similar at a lot of DO schools.
Sure.
So this was not, a lot of this was a refresher for me from like many years ago. I just had to I remember that, looked it up,
I don't want to out you, but you went allopathic after school, right?
I do. I will. We'll get to that.
Okay.
But yeah, I did. You can't go right. Can't go
Sorry.
out of order.
Dude, spoilers.
I'm looking at your face, man. I'm not looking at the document.
It's fair.
Trying to be present.
Indeed. Well, so in 1874, that's the the very same year that we had a bunch of historical developments and exciting new prospects, such as the first zoo opening in Philadelphia. Harry S. Parmalee patented the sprinkler head, and the formation of the World Postal Union in Bern, Switzerland. Like, finally.
Thank God,
I
man.
don't think a lot was happening that year. Anyway, this is the year that A.T. Still, quote, flung to the breeze the banner of osteopathy, end quote. And if you're wondering where I'm quoting from, it's from his autobiography.
Oh,
Nice.
And so
he wasn't grandiose.
Nice.
He was just like a nice salt of the earth guy.
absolutely.
They all talk
absolutely.
like that then, though.
Yeah, you're
Everybody
right.
talked like that in the 1800s.
That is fair. So, I guess it does sound better than, like, quote, I made up a new
That's
kind
a
of
nice
medicine in
phrase,
response to
actually.
a personal
Yeah.
tragedy,
Mhm.
end quote. But yeah, so that phrase
It
gets repeated
inspires
over.
me to want to fling my breeze somewhere.
Yeah, that's why I asked you, fling your breeze. So yeah, there's got to be
Febreze your sheets.
however many either students or physicians are I'm sure you've all heard that phrase before, because it's just one of these things. So that brings us to, what is osteopathy exactly?
Shoot, I had a question.
Okay, go ahead. It's a safe
No,
space.
I forget.
Okay, if it comes
Carry
back to you,
on.
you let me know.
I will.
Yeah, I will. All right. So what is osteopathy? If you're an etymology nerd, and you will note that the word almost literally means bone pain or suffering. And, because osteo is bone and pathos is bad thing. And A.T. Still's basic tenets of osteopathy included the following. So 1, the body is an integrated unit of mind, body, and spirit. Number 2, the body has an inherent ability to heal itself.
I like both those things.
Fine. Number 3, structure and function are reciprocally interrelated, or in other words, like the anatomy, musculoskeletal system, and the physiological functions of the body are completely dependent on one another.
Mm-hmm.
And number 4, that rational therapy is based on a consideration of the first 3 principles. And honestly, I think that's kind of phoning it in a little bit. You're like, I just wanted a 4th item for the list.
Yeah, maybe he
It's like-
had like even number things.
Yeah, it's like
Tenet
okay,
number
just-
4. Remember the first 3.
What about
Yes.
number 5, AT? Throw the better.
We stop at 4.
Those are cool. I
Yeah, they're not
like
bad.
them.
They're
Yeah.
fine. I mean, they're fine. But, so what by itself, none of that is revolutionary. I mean, that's okay, cool.
Well, at the
That's
time.
not, what does that have to do with osteopathy? Well, in the context of that, this whole new way of rethinking medicine, basically the musculoskeletal system to A.T. Still was the foundation of health, and that its proper functioning and diagnosis is the key to treating and even diagnosing all disease. So, like, in other
we
words,
just like,
All?
this
Did you
is a
say
nice looking
all?
path, and then we went just right off into the
Where-
weeds.
if the musculoskeletal
Only Sith
system is
deal in
out of
absolutes.
whack, anatomically speaking, so too will the body systems malfunction, and vice versa. So, problem arises in the intestines. You might find evidence of this in the musculoskeletal system, for instance, and soft tissues, and vice versa. Maybe a musculoskeletal problem can cause problems in the visceral organs as well.
I mean, now I have a much more skeptical look on my face.
Yeah.
Well, you see, this young man sprained his ankle, and now he's pooping blood.
He was the line the ankle. Yeah.
See,
okay,
in the notes, listener, I
okay.
wrote here, I'll pause to let that all wash over my MD colleagues. and this is what's happening. And so maybe I should add at this point that at the time that A.T. Still was, flinging his banner around, he got really into spiritualism and a lot of those things. And so you're going to see that this will inform some of these things. So
He
practically,
didn't write this stuff on like a stone tablet, did he?
no,
And then say that somebody
well,
handed it down from the top of the hospital.
No. I mean, when I found my own kind of medicine, I'm going to do that, but that's just because that's my personal flair.
Nice.
So, practically speaking, in the beginning, osteopathy was a purely manual manipulation type of medicine practice. Hands-on diagnosis of the musculoskeletal system, trying to manipulate bones into place. That was all that osteopaths did back when this began. And A.T. Still believed that an in-depth exam of the patient's spine and other joints would basically give you an insight into whatever medical maladies they might have. So by manipulating the spine and other joints and soft tissues, you put them in a better alignment, one would probably improve the overall health of the patient. And to take this to maybe more extreme examples, you put the spine into a better alignment, and maybe your heart works better, your intestines work better, etc.
So he was a chiropractor.
We'll get there.
I mean, less harmful than bloodletting. I mean,
that is
guess.
actually scientifically
This is-
proven to be true.
remember,
I mean,
there's a
until you do
no harm, and then-
the neck twisting stuff, but we can
Yeah.
get into that. Yeah. And, there's a kernel of truth, right? So especially things at that time, I mean, tuberculosis would go to the bone and go to the joints and so on. So there is the musculoskeletal system does
You were
reflect
very kind. You were very
systemic
kind. I
illness,
appreciate. I should be the one trying to defend these precepts,
Yeah.
but all right. So when the musculoskeletal system and soft tissues are deemed to be pathological or just communicating an underlying pathology, this is referred to as somatic dysfunction, sort of a term that's used within osteopathic medicine. And by the same stretch of the imagination, one could theoretically do an exam of the spinal area or the soft tissues around it and figure out what's going on in your organs. Kind of said that a few times, but this is just trying to hammer it home. In the early days of osteopathy, this focus on manual medicine was also kind of put forward to eschew actual traditional medications, which AT still wanted to use manipulation only and really did not want to have medicines or pharmacology involved. And I mean, okay, this is the time when it was everything was, mercury containing calomel, arsenic, and piles of opium prescribed for everything.
Saved a lot of lives, right there.
I mean,
he backed into the right move. He backed into it.
Right.
It's called failing correctly.
That's right. Yeah.
So I mean, a lot of these medicines could be harmful. Certainly not good to take mercury for any reason I can think of. But those medicines did not cure bacterial meningitis. So I'm not going to begrudge somebody saying we should do something different.
Oh man, I'm sure. Is there some deep psychological thing going on because meningitis manifests with this incredible pain and tightness with any sort of movement of the spine because the spinal canal, the CSF or the fluid around your brain circulates around the spine. So meningitis patients that are really sick, if you move their head a tiny bit, they hate it and it's terribly painful and they get all this back pain.
He made this association between illness and spine issues.
At some deep
because
level.
I will tell you, I don't know the answer to that, but
we know it's true.
It's not implausible that he could have made that leap. You know what I mean? So over time, and honestly, extending to the present day, osteopathic manipulative medicine, which I will abbreviate as OMM, you may also hear it called OMT, which is osteopathic manipulative therapy or treatment.
That's the spiritual part.
That is that's the mind, body, spirit. We're back to it. This evolved several general types of kind of diagnosis and treatment. And in osteopathic medical school, and again, to this day, basically we as DO students, we get all the normal medical school classes: anatomy, physiology, pharmacology, pathology, microbiology, all that stuff, you name it. But in addition, we have a 4-hour class once a week. At least that was mine. It was 4 hours to learn osteopathic manipulative medicine, OMM principles and treatment, and many of which are basically originally derived from some of the original teachings of AT Still, and then a lot of his early osteopathic disciples. I won't
Could you imagine flying a plane that was the Wright brothers made?
That's the thing.
Come on, AT. Come on.
We don't have 4-hour classes on Osler every
modernized.
You kind of get sprinkled in here or there.
Well, so
I wonder if it was written into a contract, you have to do this for 100 years, and then after 100 years you could stop and just be a medical
every
school.
Week. That's a lot.
You have to. Sometimes you have to wonder, but I'll say here. I mean, I can't say that I personally can speak for all DOs, but when people ask me to describe kind of what OMM is, the best way I can describe it is that it's sort of a spectrum of things, that some of which may have a little semblance of physiologic plausibility, but it goes all the way to embarrassingly pseudoscientific nonsense, which I will call for what it is, and a lot of DOs will as well. And this is where it becomes kind of interesting to see how we as DOs evolved into your just general modern physicians. And the fact of the matter, though, was manipulative medicine was once the only thing osteopaths could do as a medical intervention. And we'll see. This has now become, interestingly, a very small part of our practice. So on the possibly reasonable side of that spectrum I mentioned. I'm just going to give you guys a few examples of some techniques and things that we would learn. There was something called muscle energy. I think this has a different name under physical therapy, but it is used by physical therapists.
It's brought to you by Bang energy drinks now, but go ahead.
I was going to say, one of my issues, like you're hearing this going, I don't know if I can believe something called muscle energy, but this is kind of on the spectrum, but there's some feasibility here. Basically, it involves improving mobility in joints. So like, you have a stiffness in moving, I'll just say your back rotating to the right or something. You have somebody resist your ability to twist the other direction for like 5 seconds. You relax, and then you push the other direction to kind of loosen a little bit, have them flex again and resist and relax. Physical therapists do this, and you can actually see and measure improvements in mobility and those sort of things. So there's at least something here that an activated resisted stretch can relax a muscle, etc. Okay, not bad. In fact, this is one of the only things I still do. Like, this is how I generally will stretch before like playing hockey and stuff, because it actually does work pretty well.
You stretch? I only do that one groin stretch when you're on the ice. You put your legs apart.
Well, yeah, it's because everybody likes to be in that position on the ice, which is
you're
weird.
supposed to stretch after now, aren't you?
Yeah,
you do like active warm up,
stretch,
and then after you, or anyway. But
we don't do that.
Seems quite plausible.
Yeah, so that's fine. I mean, and you will see very similar. I just forget the terminology, but you'll see a lot of similar treatments through physical therapists and ways to improve mobility. All right, hey, not too bad.
Stretching good.
Good job.
We'll move to the little closer to the middle of the spectrum of plausibility here, and there are others to choose from, but I'm going to pick one that probably people are somewhat familiar with, and this is something we call HVLA treatment. This is high velocity, low amplitude treatment, and this is the best way I can say is this is going to look like chiropractic treatment. So is where a person is positioned in a variety of ways.
I knew
depending on what you're
guys treating. Were chiropractors. I knew it. Damn it. They knew it.
Look at me. I can write a prescription too.
We're going to get there too. So you move somebody, like you're trying to improve like pain in this area of the back, and it won't move, or you don't think it's moving very well. So you kind of line it up to where it doesn't want to go. And then you do a very short, quick thrust with the hands to like move it. It typically results in a nice, satisfying pop or crack of the joint, and everybody is cured. No, they're not. But a lot of patients will report, and we as students have to practice on each other. It might feel better. It might kind of loosen you up a little bit. But this is definitely where you get that overlap where people will be like, wait, so you're chiropractic or not? But there's a reason for this, and it just so happens that D.D. Palmer, like the father of chiropractic medicine, if you will, he wrote about taking a course in osteopathic medicine in 1899.
He just copied you guys.
He didn't.
Yeah,
he did.
Now, I believe from what I've read about this, he never said like I took this, but a lot of
course
people
he didn't
suspect.
say it. Yeah,
right.
But
So a
his
lot of people
entire
suspect.
family died of scoliosis.
Yeah. Lance Armstrong just had that much blood, everybody.
That's right. Where I think the little bit of difference without getting to the weeds is that like chiropractic is really spine focused, whereas osteopathic is like any other musculoskeletal plus the spine. Whatever. I don't want to get into the weeds too much, but there is definitely a lot of overlap there. And so you will have a lot of DOs, and even I can't help the reflex to bristle at it a little bit because it's different. But yeah, a lot of us are, including myself, are taught a system of kind of pressing on the spine, surrounding soft tissues to see if a vertebral segment is like not rotating well or not moving well or bent strangely to try to put it back in its proper place. And I put this in the middle of the spectrum of plausibility because there are some anatomical things that don't suggest that this may be true. But on the flip side, there is of a lot of things in osteopathic medicine, there is some research here that suggests it might help low back pain in the right patient.
I usually don't like strongly discourage chiropractic involvement.
Yeah.
But like I don't, when people have low back pain, I'm like, well, I don't have much for you, so I don't, go ahead, for low back pain.
I typically won't begrudge trying anything.
Yeah, I'm like, go ahead, because I'm just going to shove a lot of like just morphine at you, basically. That's
usually,
what
if they're
I
in
got,
a lot of
Go
like,
see Dr.
severe
Aaron.
pain, severe pain, I usually say don't. But like,
well,
for
because a lot of
maintenance,
people
I
will
think
have a
that's
little bit
good.
of worsening. Yeah, if it's exacerbated, they might not. Yeah, but this is the one where I think I see the plausible nature for sure.
Yeah,
Mhm.
and I,
Yeah.
you know, whether the thing that's always difficult, and again, I won't make you guys go through like a learning of like how the underlying principles of why they think this would do anything. Anyway, it's well beyond the scope. But
You're keeping something from us then. The way that you said
it is
that,
part of
there's
the DO
something
secret.
dark that you don't want us to know about the profession.
Oh
You
no,
s-
I'm going to get there right now.
Okay, good.
Actually, yeah, no, this is where. So, moving to the other end of the spectrum into the insanity, as I put it, is something called cranial osteopathy. Have you guys ever heard of this?
No, but it sounds.
No.
Is it like
nuts.
phrenology?
No, but yes, in that it's also not real.
Mm.
So this, this is where I and plenty of people I know from my DO med school had this sort of moment of career choice existential crisis. And everything gets better. This is the end of this whole story that I'm telling right now is a good one. So I should have said that a little earlier, but I'm going to take you to a weird
You're
place.
making me nervous, Max.
Yeah, you should be. So you just have to like picture you're sitting in this vast lecture hall. These are where we had these amazing lectures on anatomy, neuroanatomy, microbiology, and pathology. And we're being presented with the principles all of a sudden of cranial osteopathy. And this was startling. So cranial osteopathy was developed in the 1930s by Dr. William Garner Sutherland, who was a DO, of course. And the tenets of it held that, contrary to basically everything we learned and will know and what is true, the bones of the skull, even though you guys may think they fuse together and they don't move after childhood, about the age of 2 is when that happens, they actually can move. Did you know that?
They probably can with enough force.
That's no. This
Just can't move
is
back.
normal daily activity. Normal daily activity. So
I'm seeing if I can do it right now. Let me see. I can.
You did, Aaron.
Can we-
I just saw there was a little thing on the side of your head. Yeah.
I think that's his masseter. But that being said, there was a belief from Dr. Sutherland here that the brain actually has a pulse. They called it the cranial rhythmic impulse that goes about 8 to 14 times a minute as the cerebral spinal fluid, that fluid around your brain, basically goes to and fro, goes in and out, that it actually can move the skull bones just slightly enough, and that if you were attuned to this, you could not only check how quick that pulse was, but if it was too fast, it might mean something, or if it was too slow, it might mean something. You got to do something to try to restore it.
He was just feeling his own pulse in his thumb.
I mean,
Only 8 to
but his heart rate
14
would be going
times a
8 to
minute.
14 times.
He was
He had a
athlete.
He was in by
fetish. He just wanted to put his hands on people's heads. And
That's as
hold
good
it
as
there.
an explanation as anything. So I was sitting in class, and this is like up on the PowerPoint, and I'm like, what?
They made a PowerPoint.
Did everyone
of
have to
this.
say-
That
You
is awesome.
guys know me
That is
very
so
well,
awesome.
right?
Yeah.
You guys know me very well. I think it'd be fair to say I'm a very staunch skeptic. I'm a very rationalist kind of person.
You're a contrarian.
And when this happened, like midway through my first year, I think it was in medical school, I started to wonder if I was like, wait, what is happening? Like, what is this? And this is one of these things that was kind of founded earlier in the DO profession that has somehow persisted. Now, it gets taught. And my understanding is our school would teach it one way, other schools teach it another way. Some schools would just say, like, this is a historical thing, like, just let's move on. Some schools teach us as this is a real thing. And a lot of us were like, wait a second, very, very perturbed by it. And look, they've done lots of research in the DO world to try to prove this. Nobody's proven that this thing exists because it doesn't exist. I'm just not going to mince words on that. It really doesn't. And so, more recently, you actually finally have a lot of DOs speaking out and saying, this needs to stop, please. This is like embarrassing. And so I'm sharing this opinion that as you might imagine, this is like completely garbage bunk, and it doesn't belong in a medical school curriculum outside of a mention in historical context. But there are people who vehemently will disagree with me, and I wonder if this might be one episode where I get letters about it.
Oh, you think this was the point that you might, hear about it?
I'm just saying this is something that kind of some people are adherents to this. Now, it's very small. It's a very small proportion of DOs who seem to buy into this. I will say that. So it's pretty rare that you're going to find somebody who does.
Every once in a while, some of the doctors, they come up and they just feel my head while I'm working, and I'm like, "What are you doing, man?"
It's because it's perfectly shaped.
They don't.
People are attracted to symmetry.
They don't. Things are hard to get out of medicine. It is
Yeah.
true. Like once you start doing stuff and
Mhm.
there's adherence, for whatever reason, we do hold on to things way too long, but usually not from the 19. Trying to think if there's
something
anything we
like
do
this too. Like, yeah, one person seems to be like, yeah, I'm into that. And then the next
So
person next one was like,
confident.
oh, okay, yeah, you know what? I guess it's reasonable. And then the entire class believes it. And then
Well, and
for 60 years, they teach it.
it's probably another good
Mhm.
example of the power of placebo, right? Because placebo has a measurable effect. So that all these treatments probably do make people feel better or feel a certain way. This could be a very powerful placebo because you have somebody who's like laying on hands and,
Oh, absolutely.
you're like,
and
oh,
I
I feel
and I think there's a
better.
lot to that. I think
wow,
there's a lot to
you
that.
aligned my brain pulse. It's so much better.
It's if you were, especially if you're the type of person who would be looking for something kind of
Yeah.
outside the norm,
Yeah,
like
yeah.
this is so different that you might feel better. Right? Like I don't think it did anything, but you might feel better, and I guess it keeps you coming back. So that's the spectrum. That's the really far end of the spectrum. And so,
then-
fortunately,
You could
But
bill
then
a
it
lot
wasn't
for
that
this, man.
far off, like back then. You know what I'm saying? Like allopathic and osteopathic teaching, I would think that they're not that far off. There's this one little thing that's different. And then back then you couldn't prove or that this wasn't a thing.
Right.
So it probably wasn't like now it sounds like.
Yeah, I mean, mentalism and
insane.
magnetism were probably in a similar
oh,
time
AT
frame,
still was
so.
big into
Or
magnetism
eugenics
too.
were around the time that this guy came up with that,
Right.
like 20s
Yeah.
and 30s.
Ooh.
So there was a lot of dubious science, quote
Yeah,
unquote,
for
right?
sure.
So yeah, it kind of fits in that time period.
But let it go, man.
But at your school, Max, they taught you this as if it was
I will put it this way. So my impression. So they taught this as a yes, and they had us practice this.
Did you get
this.
tested?
when
Yes.
and when they
Yes.
said it, did you have to say this is the way every time?
No, but
And the brain pulses.
it
This
felt
is the
that way
way.
sometimes. So no, I mean, truthfully, this was so jarring to us that a lot my close friends in medical school, we got to a point when we were at the end, because you would actually get tested on your ability to diagnose osteopathically, not just the cranial stuff, but like the other stuff, the spinal segments, and especially with the cranial stuff. We there was one day in class we were supposed to be practicing for our upcoming practical, and we just sat there. And when we were asked about it, we said, we don't. This is nonsense, and I'm embarrassed to be sitting here. They left us alone because we just,
Because they
what
knew
are
that
you
you were
gonna
going to
do?
start protesting and they didn't want to be
Well,
in the news.
this is something. Honestly, this
Yeah.
is something that doesn't get talked about a lot. We don't have a big megaphone, but this should not be part of a
Yeah, well, good
reasonable
for you for
scientific
standing up.
profession.
Yeah.
Yeah, I mean, and it's still like it gets me all fired up to this day. So with all those principles in mind, let's go back to kind of how DOs moved from that to like normal functioning, well-respected members of the medical profession, right? So the first DO school was founded in Kirksville, Missouri by A.T. Still himself, the American School of Osteopathy. That was in 1892, and it's still in existence to this day. And until the 1950s or so, DOs only did manipulation-type medicine. Okay, so there's no pharmacology in the early days. However, in 1929, I should say, just about 10 years after A.T. Still had died, he died in 1917, they start teaching pharmacology in DO schools. So they couldn't prescribe yet. They started teaching the principles of pharmacology. I'm sure AT Still would not have liked that, but the times were changing. We had better medicines. It was not everything was mercury and opium anymore.
Right.
So,
Right.
they kind of started to adapt to this a little bit. So at this point in the early 20th century, DOs are becoming a little more traditional medicine in the time. So a little bit more mimicking MD medical training. And at that point, the profession really starts to try to legitimize itself a little bit more on those grounds. And this was a long uphill battle for like the last part of the 100 years, to be honest with you. And we'll go through it. But the first big test that DO schools actually passed was something called the Flexner Report. Have you ever heard of this? I'm just curious.
I've heard
No.
the
Okay.
name.
Yeah. So what this was, so I had mentioned before that medical education in the U.S. was a mess in the early 20th century. And just before that, you could be a doctor if you wandered around behind somebody and they were the right person. And there wasn't really any standard medical curriculum. You could go to Johns Hopkins or Harvard and you're going to get like the best they had at the time. Or you can go to like Bob's medical school out in the middle of nowhere, the Western U.S. And then you have an MD degree in quotes, but really you're kind of a quack doctor. And so there was really no consistency. And so what ended up happening is the Flexner Report, and I forgot his first name. Alfred Flexner or something like that. Anyway, he puts together this giant kind of status report on medical training in the U.S. And he said a lot of these schools are abysmal, and we should call them out for what they are. And that there's too many physicians and too many incompetent physicians, basically, for the time. And we need to make sure that medical schools are consistent and reproducible. And like Johns Hopkins, I believe, was the model that he used. They said that this is what it should be. So in 1910, this report comes out. There were 155 medical schools in the U.S. By the time the report hits, and after it did its work, there were 31 schools left.
Jeez.
So this basically culled a giant amount of schools. And believe it or not, a lot of the DO schools, they had to adapt a little bit of their curriculum, but they passed because for all the weirdness that I've already talked about, the other thing was A.T. Still, when he started this, he was just a very, very meticulous anatomist. And he really thought anatomy and the musculoskeletal system and learning was so important that even to this day, my medical school, our anatomy was crazy rigorous. And for all that I've probably forgotten in the minutia, like I really always had a very good foundation in anatomy. And so it wasn't too hard for them to adapt their curriculum to more modern medicine standards of the time. And they passed the Flexner report. I believe all the DO schools did. And all those original schools are still around today. And so it was kind of the real first legitimizing of DOs as a potential real, medical provider of the time. But that's also still during a time when we can only do manipulative medicine. In the 1950s, the osteopathic practice starts to incorporate a little bit more of those primary care concepts. They do more preventative medicine. DOs would go into family practice where they would still do manipulative medicine, but they were learning pharmacology. And so as the pharmacology had been taught in in DO schools for the last 20 years, there were, interesting growing pains along this time, because even though you learned pharmacology, you couldn't always prescribe as a DO at that time. I've got a really cool personal anecdote about this, not because I was around back then, but it just so happened that when I was in medical school, a gentleman lived in the apartment building down the way from us, my wife and I, and he was a retired physician. He graduated from my school, and it was like 1958 or 55 or something like that. He was quite an elderly gentleman, but he was a super nice guy, and he loved living in the building because it was somewhat near the medical school. And if he found out you were a medical student, he'd take you out to dinner and just tell you stories. It was awesome. It was like a great experience. But one of those stories, he took us out, my wife and I out, we had dinner, and he said, he was telling us that in the 50s when he graduated, he was practicing in a hospital, but DOs at the time there could not write prescriptions. And so they had to have an MD friend sign all their prescriptions to make them official, even though they were doing the same things. And he was in the military at a time when the very first DOs were allowed to practice in the military. And that's kind of a big segue here. In the 1940s and the 1950s, the DOs start butting heads with the MDs of the American Medical Association. And this is kind of where a lot of, I think a lot of the professional infighting that maybe, I don't know that you guys were ever, this probably was something we as DOs in school thought about a little bit more, even though it didn't affect us as much as maybe we thought it did. But it definitely did exist to some degree. But in the beginning, in the 40s and 50s, this was like written down. So as recently as 1961, the AMA Code of Ethics had actually declared it, quote, unethical for a medical physician to voluntarily associate with an osteopath.
You gotta love the AMA, man. So
Wait, so we were breaking AMA code right now?
Not now. This is after 1961, so you're good.
So now we're going to have a bunch of individual osteopaths coming after us and the AMA.
Aaron, they can bring it, man. We should get in a fight with them. Poor historians versus AMA. We'll get
poor historians versus the world.
That's right.
But so, honestly, as harsh as the AMA stance was at that time, I kind of see how they got there. I'm going to take basically in 1954, there was a physician, I think he was prominent within the AMA, named Dr. Charles Farrell, and he wrote many kind of letters and like papers on the topic. And there were some excerpts I came across, but his argument was, look, I mean, he did not think DOs were at the practice level of equal to MDs, and because he said they're kind of operating like a cult. And one of the things he cited was that, a 1952 osteopathic textbook basically stating that, quote, A.T. Still's discoveries have been progressively confirmed and never invalidated, end quote. And that wasn't true at all.
Yeah.
A lot
And
of
it
those
goes
initial
against science.
Yeah.
and
yeah.
that was his
So,
big
yep.
problem. He says, look, you know, I'm going to paraphrase basically what he was saying, but he said, look, until they're using evidence-based medicine, I don't know how we would admit them. And I'm putting it more polite than he did. He was quite direct about this, but I as a DO don't totally disagree with his point. You know, I think
Yeah, that's
that
fair.
I get where he's coming from on that.
Well, especially because it's founded around a cult of personality. It's this
Yeah.
AT Still. Just imagine if
Which
medicine
you guys
had
still
like,
know. I mean, we don't really
Right.
have one. We have Osler.
Like
we have
Phil
giants
McCracken.
of medicine, but they're not like, oh, you got to follow the way of Vesalius and
but
no
not
one
a
else.
recent guy that there are photographs of.
Right.
You know,
Yeah.
like,
Yeah, perhaps.
it gets
No,
a little.
and you're absolutely right, because it is. I mean, I think I said it many episodes ago, but like I believe I said it to our guest, Dr. Brian Elliott, if I remember correctly, because he had, I came across a description of osteopathy in his book, and I think he was very fair to it. And I said, yeah, the thing that always made me nervous about some of this stuff when we talked about like the cranial, et cetera, was that they would speak about Dr. Sutherland in this like sort of venerated way, because like he was, I don't know, he was a early founder of this, so therefore he was right. And no, he's not. It's not. There's no science behind this. We should not venerate somebody just because they were a big name in history. It doesn't make them right.
But you're going to get behind them if you don't believe that your profession is at the standard of the other profession that you're competing with. So you're going to be like, look at all of our guys. Like all of our guys are stellar.
Mm-hmm. Yeah, no,
You're going to talk yourself into it.
I can see how you get there. I can definitely see how one gets there, and it's just not the good way to go about practicing evidence-based medicine. And so, if we look at this time period from like 1916 to 1966, basically osteopaths were like in this, as they described it, a long and tortuous struggle to basically serve as physicians in normal respects. And they actually targeted a lot of these efforts on the military. So like in World War I, World War II, osteopaths could not practice with full rights. And that makes some sense. I mean, they can't really write prescriptions at the time, et cetera. So, but they were kind of looking for this, validation, or this, what am I trying to say? They're looking to become a, like certified specialist. They're trying to become more normal physicians. And so it wasn't until like May 3rd, 1966, that the Secretary of Defense, Robert McNamara, authorized DOs to be accepted into the military in all branches on equal practice basis as MDs. That's a huge step for the DO profession.
Mm-hmm.
So then at this point, as DOs are practicing more traditional medicine, now we can prescribe things. Now we're in the military as physicians. We're using the pharmacology. And we're not relying solely on manipulative therapy or, manipulation treatment. There still come a few more hiccups. And so one big example I kind of alluded to in the beginning was in California in the 1960s, where there wasn't much else, going on historically speaking or culturally. Yeah, not much happening there.
Is that the gold rush?
Yeah. The AMA at that time spent $8 million to stop osteopathy in the state. There was something called Proposition 22, which was a statewide ballot initiative.
Seems like a lot of money.
At that time, $8 million was like $84 billion in today's money, if I'm not mistaken.
I think it was 10 trillion.
You know what? You're right. I forgot to carry the one. So they spent all this money to put this proposition across, which basically barred DOs from practicing at all in California. And at that time, the California Medical Association offered to issue DOs an MD license if they paid a $65 fee, and they took a short seminar to bestow them with MD-ness, I guess. And you know what? 86% of the DOs in California at the time took them up on it.
It's a big fee too, $65. That's
yeah. Back then, that's $80,000.
But the writing's on the wall there. It's like you could either do this or you're dead in the water.
Well, and that's. So, this gets kind of bandied about a bit. When I look at it, like if you imagine you're a physician, you're a DO in California at the time, you have a family, you have a practice, and they're like, okay, you can't practice anymore, or you can pay $65, take the course, get an MD.
I mean, they kind of offered him
career.
Shelter for a nice fee.
Right.
Interesting.
Basically. I think that played a pretty big part in a lot of physicians taking it up on it. There are some though that were like, "Yep, that's great." I'd like to avoid the confusion that sometimes comes with me seeing patients and then like asking me about my degree. I have no idea how much of one or the other. I suspect the first thing was probably the biggest driver, but this was a thing that was kind of seen as a black eye on the for DOs at the time.
But 14% were AT still acolytes.
I would
We
imagine
will
so.
never give up the brain pulse.
Never. Although, and to be fair, AT still didn't do the brain pulse thing. That was the other guy, but
Okay,
it kind of derives from, it becomes under the umbrella. So the AMA at this point reaccredits the University of California at Irvine. That was previously the University of California at Irvine College of Osteopathic Medicine. It becomes UC Irvine School of Medicine. And they banned the issuing of MD licenses to any DOs moving to the state from out of state. And so they got rid of the osteopathic school. You couldn't get an MD license unless you had already lived there and paid the fee, et cetera. And so there you go. This all stood in place until 1974, when there was a bunch of protests and lobbying of the California Supreme Court by a bunch of prominent DOs, and eventually actually allowed osteopathic licensing to resume in the state. And so, believe it or not, actually, the DO degree was not recognized in all 50 states until 1973.
You know, it's interesting though, like organized medical school curriculum with DOs and MDs started at essentially the same time.
More or less.
Like
it's fairly close.
Allopathic medicine existed before that, but like with the formal training kind of started. It's just interesting how this, like, you have this black sheep, and it honestly probably was some of the weird stuff about it. Maybe these schools back in the day, they'd be like, we're not going to do chiropractic stuff, and we aren't going to look at brain pulses, and then be like, okay, you guys are cool.
Yeah, or we're going to do it, but we're going to do most of your stuff too.
Yeah.
And therefore, okay, fine. So that kind of rift between DOs and MDs really kind of starts mending around 1969. And the AMA actually says that the AMA said, you know what, we'll welcome DOs to be part of the AMA, and you know what, you guys can come to our residencies. DO residencies came along a lot later than your MD residencies, and there weren't as many options. So, for instance, if you graduated in the 70s as a DO, there were no DO emergency medicine residencies even at that time. There weren't all the specialties that we have, so your options were limited. So when the AMA said, "Why don't you come to our residencies?" and gave that option, it was a big deal. And you would think the American Osteopathic Association would be thrilled about that, but they weren't.
So they're like, we're going to make our own residencies and make it really challenging for you because you're going to have to get boarded in both specialties.
Kind of,
all the
yeah.
boards.
I mean, so the AOA...
So they turned around, they became kind of dicks, right?
I mean, more or less, yeah. I mean, so they basically said, yeah, we don't want to be like MDs, so we want to keep this distinction different. Therefore, they were resistant initially to those efforts. Eventually, things do lighten up and people are allowed to go into MD residencies. You mentioned earlier, I myself went to a quote allopathic or MD residency by my choice, and it was, at the time, it was a headache because I had to take not only my DO boards, 3 different giant tests, I took all of your boards, the MD boards, 3 different giant tests.
I did not realize you had to do that. Much respect. That's pain. That's so painful. That's painful.
But I thought you would have to do that if you did the osteopathic residency. So are you saying it was an easier course if you do an osteopathic residency? Then you're
it
only
would have
boarded?
been in that case because I would only have to take the DO boards and I could have applied there. And it wasn't that you could apply with just the DO boards, but we all knew that you were more competitive if you took MD boards.
Oh, you're saying
so we all did it
for residency, like for the match.
Right, correct.
So
to get into the residency.
Can you be certified through ABEM through DO, or do you have to be allopathic?
Good question. Basically, what Mike's asking is, does my board certification in emergency medicine, does it come through an MD board or a DO board? At the time that I did, I am certified through ABEM. That's the MD board. We do have ACE, the osteopathic equivalent. Yep. But I would have to do special training to actually get certified through them. So I maintain MD certification as it stands right now.
So it's all the same tests except for secret answer E.
Basically, yes.
Deranged muscle energy.
More or less the same test, but I'd have to answer questions on the DO boards about like some of this OMM principles.
The last one, yeah, AT still was right.
Yes or no.
Yes or no.
Invalidates your responses.
This patient has chest
almost-
pain.
I don't think
What
it was
does the
that
ankle
bad, but it was-
exam show?
There were a few. But we would have, I mean, honestly, we would have questions on cranial osteopathy. And I'd just be like, I don't like that I know the answers that they want, but I mean, I knew I would study for it like a game. Like I didn't think any of it was real, but I at least knew the answer they wanted. So it was hard. And once I was done with it, I haven't had to take a test with those questions on it forever. And I should not have to again. That stuff is all gone and from my memory.
And I don't know if you're going to touch on this too, but I do remember like not knowing anything about osteopathy and coming into residency. And that's the first time I ever see a DO.
Mm-hmm.
And looking at that residency thing, we had a couple on our list as far as our residency class and just not knowing like what that
I didn't know
meant.
either.
You know, it was
what?
like, does this mean now that there's a lower quality in our residency? Like not knowing what like a DO, what? So I was one of those people who had no idea.
Well, yeah, we're all MDs, so we're a bunch of dicks, so we're like, oh my God.
Right. But then like the other thought was, because there was a bunch of DOs in every residency, but I feel like before that potentially was primarily primary care.
You're absolutely right. No, you're absolutely right, because those were some of the first residencies that were available to DOs. A lot of DOs, and I think to this day, I forgot the stat, but a lot of DOs end up in primary care. Just kind of, there seems to be a gravitation towards family practice, internal medicine, and things like that.
It's the whole mind, body, spirit thing.
Well, that is one thing that gets brought up. Like, there's a phrase, I've said it a few times, the DO difference, and what does that mean? And it's typically tough to define. There are some patients that will say, I only see DOs, and it's like, why? It's like, I don't know. They just kind of, and I'm not saying that that's necessarily a valid point. I'm really not. I'm just saying that there's maybe it's because we've gone through this sort of alternative but similar schooling. I definitely had a chip on my shoulder. I'll be honest about that I wanted to be really good at my job because of it. Because sometimes if you show up to a place where there's no DOs, it's sort of, wait, what is that? Why is it different? And you're kind of right that some people will at least jump to a conclusion that it's a lesser thing.
Well, the core principles are different. I mean, the core principles are, that if you're starting from a different space and a little more holistic, outlook, that can be very useful. And it's a good thing. It's probably, one of our blind spots, I would say, on the allopathic side. We're so systemic and mechanistic, and like there's no mind-body connection because you can't prove it with a transmitter. Like that's an oversimplification. I don't think that's entirely accurate, but it's probably one of our blind spots that we just don't think about that as much.
I think they're getting better at that.
And that was an unfair characterization of us too. But I think that is, when you start from those principles, you sometimes go back to sort of excluding some of those things that might be helpful. So
and I think the way I always put it, if somebody asks me if I think there's really a difference, look, a really good physician should take a lot of those things into account, and a really good physician that does that, you will know it when you're talking to them.
The art of medicine for sure.
Yeah, and I don't know that that's a specifically DO thing. Maybe there's some more of it, but I don't know that that's true. I really don't, and so I don't think it's fair to say it is. Yeah, and it might be the individuals that go to DO school is a little bit different. I don't know. I really don't. It's probably been studied somewhere, but I'll be honest, I didn't look it up.
What are the acceptance rates? Is it like easier to get into DO school, harder to get into DO school, equal to allopathic school?
I think generally, a great question. Numbers wise, I don't have numbers in front of me. I will say that you are more likely to see more non-traditional students in DO schools that might, students who are a little bit older, who weren't, going straight to medical school right out of college. You might see more of them. That was my impression being within it. So I don't want to characterize the entire specialty like that, but I think it's general that you will find folks who are a little bit more non-traditional approaching medicine. And I was one of them in DO schools. So I think acceptance is a little bit easier, albeit we take the MCAT, we take all the standardized tests and things like that. So, and there's also a lot more DO schools now. So I think by virtue of numbers, that is a thing.
And still relatively unknown. Because my son was interested in medical school, and I was like, well, we could look at DO programs too, because he wants to do the allopathic route, but just whatever, because that's what he thought.
Yeah, of course.
This is what you are an MD, that's medical doctor.
Yep, absolutely. And I was like that too. I remember I applied fairly widely. I got into a couple of DO schools, and I had no qualm about it because my father is a physician. He's a DO, and so it was like, oh, okay, whatever, but there were definitely people who would eschew it because it was a different thing, and so why is it different? And so it does play in the back. And you come forward to like 2014. That was after I graduated residency, and now all those residencies have merged. So there's no more, you have to go to one or the other. And that's, that's a big deal. I mean, that really kind of brings the two professions together.
Yeah, it makes
Well,
sense.
then, I guess then it speaks to the, like, do you need the separation anymore? Can you just like make the DO schools like you get at a medical doctor, because essentially you're saying you have the same degree. Just
that's
get rid of the confusion.
This is a big topic of debate within the DO world, and it's one of those things I can opine opinions about. I do have my own opinions. I wanted to try to do my best to try to be more objective here, but people who are listening will know what my opinions are. I think as to what we should do there. With that gradual evolution, you're right. The DOs of today are basically interchangeable with MDs. I mean, all my classmates that were neurosurgeons and are now interventional cardiologists.
Right.
They're not just in primary care. And it gets to the question of like what in the modern era really makes the DO degree and DO physicians, objectively all that different. And here's another thing. So if you look at a study, I got this from the Journal of Osteopathic Medicine in 2021. The data suggests that the use of osteopathic manipulative medicine, OMM or OMT, when they look at it, it's in pretty stark decline, right? So that was the case when I was in medical school, but it seems to have progressed even further. This particular study, they took 10,000 surveyed DOs, or they sent them a survey. I think 16% responded and said, all right, it's just a survey.
Those are the AT still acolytes. They still exist.
I actually kind of wonder if that plays a role. But even then, even if we assume that about 3/4 of the people who responded used OMM on fewer than 5% of their patients.
And this is including primary care providers.
Yep.
Because the specialists aren't going to do it. The interventional cardiologist isn't going to be like, let me just snap your neck before I go home for the day. I put in a stent in your, like, no, we're not going to do it.
You're probably not going to see that. Nope. But that being said, if you're over half of them, like 56%, didn't use OMM at all. Like just didn't ever do it. And so, if DOs aren't practicing OMM much at all in the real world, what is the distinction? I think your point is an interesting and valid one. And why have a separate degree at all? Because I'm joking about it when we write the skit in the beginning, but I've had that conversation more or less, maybe minus the liver pumping the blood joke into the patient, however many times. And it's sometimes a little difficult to navigate in a short period of time. And like I said, I do have strong opinions on this, but I'll let the listeners guess what they may be. Just so I'll talk about this for hours and hours.
For us, we've got 5 DOs in our practice, and indistinguishable. It's if it didn't have if it said Dr. Whoever on your name badge, you'd never know. The fact that it puts the MD on the back of it, that's the only reason you know. Nobody would ever know.
No, and there are a few places, actually a nice segue, because there's a few places that it can matter a little bit more. And so I'm talking about US-based osteopathic medicine, but if you go outside the country to other countries, it is actually different. And so for instance, in I think it's France and Japan, DOs can only do manipulative medicine. Even if they got trained here in the U.S. or some other place where you have DO schools that do pharmacology, etc., you cannot have full practicing rights in some countries, and that this has actually kind of even evolved since I graduated medical school. There are some countries now where you can. There are some, I believe, if this is still true, there are some territories in Canada where I could not practice fully, whereas I think most of them have done away with that. There are some states in the U.S. where I don't know if this is true today, but when I graduated, California and I think Michigan and Florida, I would not be able to get a license unless I went to a DO residency or had DO certification through a DO residency. That's actually based off the AOA wanting to protect licensing, the DO difference in those states. It's not a MD raining down on the parade kind of thing. So it gets a little goofy outside of the US, but that's kind of how it is. And with all that I've said, I've kind of aired out a lot of stuff that I questioned in my own profession. But my final thought, and the reason I really wanted to do a show on the history of my own degree, is basically leave any listener out there with a really positive impression of their DO if they have a DO physician, because the historical origins of the degree are interesting and they're worth remembering, they're worth noting. But there's plenty of pseudo scientific concepts that may have been taught or still may be being taught in the world of DO medicine and OMM, and those are just not defining features of osteopathic training and osteopathic medicine at this point, even though some people will disagree with me. DOs are in every area of medicine. We're doing incredible work. We do all the specialties and subspecialties, and DOs have been surgeon generals and every bit as capable as my MD colleagues right here, as you guys have noted. And you guys haven't noticed a difference. And I think in the end, really the most important thing is like a good doctor is a good doctor.
Yeah,
and so
for sure.
That, my friends, is the history of my degree.
Just cool. I learned a lot. I didn't know a lot of these things. Yeah, that's cool. Yeah, our chief was in residency. Was a DO. Is a DO. Yeah. And she was chief for a reason. Yeah. No, fair. She didn't change it. No, she's
my co-chief was a DO. I don't know if you know who the other chief was.
Well, there you have it. That is everything you wanted to know or didn't want to know about osteopathy. So we do appreciate everyone listening, and we'd love to hear from all of you out there, even those who may not agree with my take on this.
I think it's interesting. Okay, the question that I have, so you go to the UK, you become a physician, your title is MBBS. You go here, it's not MD.
Why do they do that? That's dumb.
And it's regional. So that's if you go to King's College and some other places and they have regional titles. But MBBS is like the big thing. Because you will see that sometimes with people that have trained abroad and then come here, like you practice with an MBBS.
Yep.
But we have MD-DO. In Japan, do they have, like, do you know what that
I have no
maybe,
idea.
Or Canada?
No idea. In Canada, I believe it's just DO.
So I just wonder, like, what, like the training would impart a knowledge set to you. What does it matter what it says behind your name? You know what I'm like? I understand, like,
no,
to some extent,
in that same like echelon, right? You're saying like this is terminal degree. You are an expert in the field of medicine, regardless.
Yeah.
Like, what does it matter? What you've already hit the highest that you could hit.
I think honestly, the probably the best answer to the question is the societal expectation is that MD equals doctor, and something that is not an MD is viewed skeptically.
Yeah.
Even if it doesn't, it shouldn't be. Even if it shouldn't be, it's still different. And the explanation as to why it's different is kind of long, convoluted, and historical. And when you start having to do a long explanation to say, no, basically we're the same thing, it sounds like you're justifying something. And it puts me as a DO in a kind of a weird position. Now, I'm going to say that some DOs will probably approach this very differently and be like, no, I look, my degree is different because of these historical precepts, and I'm very proud of that. And I'm not saying they're going to be like, I'm very proud of cranial osteopathy. No. But I'm proud that we split off and we did things differently, and now we're just as capable. There are some people who that is their driving force. I'm not one of them. Not one of them. I think a good doctor is a good doctor, and having a similar degree is very reasonable.
Yeah, and the nomenclature is interesting too. You think about PAs, how PAs, nurse practitioners, and they want lobbying to have this name change to match their profession, and then DOs like essentially lobbying to not.
Yeah. Yeah, no, it's this is like this is a long discussion that I'll tell you a lot of DO students probably have over beers at their favorite bar that they go to study anatomy. And everybody who listens, who knows which bar I'm talking about, we boy, did we hash this out over many, many hours.
It's called the Brain Pulse, isn't it? It is.
The CRI. Now, with that.
Ooh. How about a bar you call the fourth ventricle, but you also treat with IV fluids as you leave to prevent a hangover? That's actually not
that's a good idea.
Okay. Well, let's write up a business proposal. That'll work. Well, if you'd like to send us a message or provide feedback, we can be reached through our website, www.poorhistorianspod.com. There you will find links to our social media sites. We take emails at poorhistorianspod@gmail.com and work to respond to all posts on our various social media accounts. If you want to send a medical history fact or send us a question to test Mike's innate knowledge, go ahead and do so at that account or through our website, and we'll see if you win your own medical eponym. If you have time, please go and leave us a nice 5-star review on iTunes or whichever platform you choose. And if you're old-fashioned, hit us up on AOL. I can't remember, honestly, if I used that one before, but I would check. It's just I'm out of AOL hours anyway, so I can't get into my account. But until next time, the Poor Historians are signing out. AMA. I got to, I don't know if this will make a show, maybe it will, but maybe this will be an outtake. So I got so good at the nomenclature and like how the DO system of treatment was supposed to work, like in spinal lesions and stuff. It was all BS as far as I was concerned. So like if you would do these like practicals where you'd all be sitting, you'd have like you and another patient, and then the other patient was another medical student. So you'd feel their spine, you'd be like, oh, I think lumbar for L4 is like side bent and rotated to the right. No, it's not. There's like 8 different ligaments holding into place, but you're fine. So you press on their back. You're like, okay, I guess one side feels more full. And there's this whole system to trying to describe it. And a lot of people would agonize over these practicals because they would sit there and be like, I just can't tell. And then, you'd have the OMM faculty come over and double check your exam. And people would sweat this. And I figured out very quickly, I was like, this is all BS. This is all made up. So all I did was make up stuff confidently that made sense within the rules of that game. So like this based on this, like, you couldn't have this vertebrae and this other vertebrae in different directions. It just didn't work within the osteopathic principles. So I knew never to make that diagnosis.
Yeah.
But I literally got to the point where there was one person and you would have, I'd say about 3% of the class would be really into it. They'd be really into OMM. They're just going for it. And I just don't mince words about those. I was just like, no, this is BS. I don't, whatever. So we would do this practicals. And I had such a high score on practicals by the end that I literally didn't do the cranial one at the very end of school because it didn't matter if I bombed it. I would still get an A in the class.
Nice.
Yeah, because I told somebody who was a true believer, and I told them before, and they're like, you don't even believe, how do you do so well in this? And I was like, this is all made up. I'll tell you what, you're my partner.
Secret.
I'm going to tell you this. You have an L4 rotated side bent right. And they were like, how do you know? I was like, it doesn't matter. I'm just going to say that's what it is. And I said, here's what I'm going to do. I will only change that if I press on your back and I think maybe your right paraspinal musculature is less full than the left. I was like, but I'm just going to tell you, I'm going to diagnose something at that level because that's usually what they tend to want to hear. And I'm just going to pick the side that's more full, say it's rotated to that side. We'll see if I'm right. And there's also sacral diagnosis and all this stuff. And so I would just make it up. And so I was right 98% of the time because I would do it very confidently. I would pick things that are common in the world of osteopathic lesions because some people are like, oh, I think this segment's actually one of these rare ones. Like, don't do that. Come on. You got to be kidding me.
Right.
And so I would do it. And I actually got to the point where I would write down my answers beforehand, give it to somebody who was skeptical, go take the test, answer them all and get it right, like on the physical practical exam, because I knew there was nothing.
Yeah.
There's no interrelator reliability.
Right. And what your preceptor is reading is your confidence and whether it makes sense as an answer.
Well, but and it's also bunk, so they probably don't believe it either. It's like watching those karate.
They're teaching it, they might, and then they're going to have bias. I think you got a point. If he says it confidently, they're going to have confirmation bias.
Yes. Yeah.
Like if somebody comes up to you with an EKG now, and it's like a hinky EKG, and you know how they say it, they're like, "What do you think of this one?" And you're like, "Oh, they wouldn't show me this EKG if there wasn't something wrong with it." So then you look at it and you're like, "Oh, I'm going to find what's wrong with it. I'm going to see, oh, that looks wrong." And then you confirm each other, and that's the same kind of thing that would be happening.
Give you the old one from 8 years ago that looks the same. You're like, oh,
and you're like, oh, never mind, it's nothing.
But isn't that confirmation bias?
Yeah.
Or is that premature closure
that's what I was
bias?
trying to describe as confirmation bias.
Yeah.
Premature closure is you don't
you already
consider
decided
things.
what the diagnosis
They're
is,
related,
then,
right? So then you don't consider contrary arguments.
Yeah. I don't know. I had a hard time remembering things that I didn't believe in. I remember like a lot of those throwaway classes in med school in the early years. Like I could not function in them because I was like, this isn't applicable to me. Like biochemistry. Like, I just couldn't do biochemistry. I couldn't do it.
Wait, so you're telling me there's all these little things that fold in a certain way and like latch onto each other,
well, I
but
tell
you can't see them.
AT still said that this all happens in the mitochondria. It's a powerhouse of the body.
He definitely didn't say anything about mitochondria as far as I heard. I'm pretty sure I got rid of all my OMT textbooks. I think I did therapeutically. I should I just want to take you guys behind the curtain to see.
No, that's cool, man. That was cool.
Because we've already got a good, healthy perspective. And
no, I think we're good.
Fair enough.
It's like you tell us about all your traumas.
Cool. Yeah, it's truly. Honestly, I was joking. I wrote I texted all my close med school friends. I'm like, I'm doing the DO episode today, and they're like, "Oh my god, we can't wait." And so I hope that I did them proud.